Great. It's great to see everyone. It looks like it is 1:30. Erin, do you know how many of our consumer TAC members are on right now? I see Arthur.
Hi, Emily, it's Kelly.
Okay, hi, Kelly.
Hi, Erin is out right now, so I'm going to be your host today. It looks like we currently have you, Miranda, Arthur, Brenda, and Christy.
That sounds great. And if everyone can turn your cameras on if you're able. I think technically we don't need them on, for the entire meeting, but when we do vote, we do need to have our cameras on.
Okay. Hi.
Hi, good to see you.
Yeah.
And why don't we go around and make quick introductions, just your name and the organization or the population that you represent, and then we'll get into the rest of the agenda. So I'm Emily Beauregard. I'm the director of Kentucky Voices for Health, and I'm the chair of the TAC.
Hi, I'm Christy Harden. I'm the Youth Service Center Coordinator at Bullitt Central, and I'm here representing the Frisk Coalition.
And Christy, it's so nice to have you on.
Thank you.
Hi, I'm Brenda Menino, and I represent AARP.
Miranda and Arthur.
Hi, I'm Miranda Brown with Kentucky Equal Justice Center.
Arthur might be having some technical difficulties, so he represents PNA, Protection and Advocacy. And Kelly, did I miss anyone else? I think that this covers it, right? Because we actually have a good seat.
I don't see Patty. She's the only one I don't see. So.
Right. So why don't we do have a quorum. And the next item on the agenda is to approve minutes from our previous meeting. That would be August, hopefully. And of course, the minutes are a transcript. So if you've had a chance to look at that, great. Let me know if you have any questions or if you think there's anything that needs to be corrected. Otherwise, I'll take a motion to approve.
So moved.
Thank you, Brenda. A second?
A second.
Thanks, Miranda. All in favor, say aye.
Aye.
Any opposed? All right, the motion carries. Minutes are approved. So we'll go on to the old business. And actually, no, I have to back up here. We're going to go just a little bit out of order. I think that Angie needs to maybe hop off early. So we're going to cover, is that right, Angie?
I don't, but Angela Taylor, who is going to be doing the presenting.
Oh, a different Angela. Got it. Okay. Thank you.
Yes, she's F on the old business and she has to leave by 2. So
Okay.
Thank you for allowing us to move her up on the agenda. But
Yeah, no problem.
I'm Angie Parker, Director of Quality and Population Health with the Department for Medicaid Services. And last meeting, I talked about a network adequacy reporting that we were working with the Office of Data and Analytics on. It's still not ready for prime time, but I thought Angela could potentially show you a high level of what we're working on. So I'll turn it over to Angela Taylor. Thank you.
Hi, I'm Angela Taylor. Just 1 second. I'm actually just trying to get this pulled up. If you could give me just like 2 minutes, I'll be right back.
Looks like the speaker's working.
Hey, Arthur. Yeah, thank you. I'm glad we can hear you. And you may have missed the introductions, but I did mention that you're here representing PNA.
He says thank you. He had a problem with his microphone.
Okay.
He was saying, that's why. That's why he was late.
Well, not a problem. We can hear you great now. So hopefully your microphone will continue to work.
Hello?
Peter,
Yeah.
is Arthur right there?
Hey, he's on the meeting right now. Can you uh
Emily, is there something you want to go over before she?
Well, we could
Yeah,
cover
I'm
this.
so sorry. I just left another meeting and I didn't have this pulled up. I'm really sorry. If you guys
No,
want-
that's okay. I wasn't sure, how much time you would need. We could go over the first, A on that item, the standing data requests, which is the number of Kentuckians currently covered under different types of Medicaid.
This is Jordan with the Department for Medicaid Services. I am the branch manager of eligibility and enrollment, and I can go through these numbers. So currently we have 143,881 individuals in traditional or fee-for-service Medicaid. We have 1,465,477 individuals that are in Medicaid under managed care. Of that population, 565,489 are in expansion, Medicaid expansion. For a total member count in Medicaid, this is individuals, 1,609,358. Emergency time limited Medicaid, we have 201 individuals. In presumptive eligibility Medicaid, we have 923 individuals. And that, I believe, covers the member counts. And I also have the renewal information if you all want me to cover that as well.
Yeah, let's go ahead and do that. Thanks.
Sure. So this question was how many people received a renewal notice, RFI, or renewal packet in July and scheduled for one in August. So in July, these would be individuals with a renewal due date of August 31st. We had 53,278 individuals going through renewal. So for passive renewals with an RFI sent, we had 11,335. Individuals that were sent an actual renewal packet were 14,663. And then individuals that were passively renewed with no RFI needed were 27,280.
All right, thank you for that. And I realized that I mistakenly did not update that from our last meeting, I believe. So do you happen to have the numbers for September and October?
I can
Putting
get
on the
them.
spot, so if you don't,
Yeah, I can get them really quickly. It may just take me a
Okay.
second.
And the other thing that was on that standing request is the number of people currently participating in a 1915C waiver. But it may be that Pam Smith is going to share that.
I've got that. Yeah, I've got that.
Oh,
in there.
okay. All right.
Yeah, Pam, you can go ahead if you want, and I'll try to pull up the updated
Okay,
numbers.
yeah, I can. So as of right now, total in all 1915Cs, we have 31,806 people that are actively getting services. So if you want to, I can give you by, oh, of course, and I don't have the math completely done. If you want me to break them out by waiver, I can do that and put it in the chat. But altogether, total, we
Sounds
have
good.
31,000.
Okay, that's helpful. And Pam, I know that I think at our last meeting, we talked a bit about Medicaid renewals for people with waivers and some of the issues that people had been having. And I know that you've been kind of tracking that, trying to make sure that people aren't losing coverage. Do you have a number of people that you've been able to either extend or re-enroll in Medicaid to keep their waiver?
I don't have a number, and I will let Jordan or I think I saw Deputy Commissioner Cecil on here as well speak to part of what's been able to be done through part of the unwinding. But what I can let you know, the top concern now that I'm seeing is related to individuals that are of an age now that they have to have that SSI disability determination. And we've been able to work with those individuals and make sure that they understand they will not lose their waiver slot, because sometimes we realize that takes longer than the traditional the 60 days that you can be without waiver services. We have the ability to kind of override that automatic program closure. So we put notes, or it's called an alert, so it shows up red on their screen. And so that will prevent the case from getting closed. If for some reason it gets closed, I can give that slot back. So we can give that person that slot back. So we've been able to ensure anybody that is experiencing any delays because of redeterminations, you will not lose your slot, because of that. As long as you are involved in the process. Now, if I have somebody that is just not responding, we're reaching out to them. We're doing everything possible to talk to somebody, and somebody is just not doing anything. So they're not responding to anybody, then after a certain period of time, we won't immediately close them, but we do have to kind of give a consideration if, after 90 days or more, we can't get a hold of them despite trying multiple ways, or they, are just not responding or not following through if we give them, directions, and have somebody, reach out and call them and say, okay, we're going to call you at this time. We need to do, you need this, and this information. So eventually it could get to a point that we would close them out, but that's the ultimate last resort. And that's really just because someone has just failed to, despite everyone's best effort, to comply with that. But that is an absolute last resort. And I'll tell you, I have not had to do that. So I don't expect.
That was going to be my next
doing
question.
that. Yeah,
so
no, I
thank
have
you.
not had to do that. We've had, with Jordan's team and our other, the other teams that help in the DCBS offices and just within Medicaid, we've not had to do that. We've been able to help individuals through that process. So
That's good to hear. I will say just one thing before we switch back to Angela. I know of some folks who, I think one of the things that you had shared with us is that a caseworker should be assisting people who may need assistance. We can't assume that everyone with a waiver or in long-term care, even though that's, a separate population, can complete the process on their own, and that a caseworker should be, participating in that and providing them assistance. And I don't know that that's happening all the time. It certainly hasn't been with some of the cases that I've heard. So when
if you
you're
let me know, yeah, and we'll verify with them, but they also, we have given the case managers the ability to bill an extra unit of case management if they have to do, if they have to assist members in that process, because we realize it can be lengthy sometimes, depending on what each case is different. You can't say it's going to be the same for each one because each individual is different. But if you get any specific examples, and we will work with the case managers too, to make sure that they understand that is part of their responsibilities as a case manager, but B, understand that if it causes extraordinary work above and beyond what is that normal case manager responsibilities, that there is the ability for them to get that additional unit of case management.
all right.
I have a question. Can I interject a question here?
Yes.
How many Kentuckians are currently covered? What was your total under traditional, expanded, all of that?
Oh, Jordan, do you have that? You have those numbers?
Yes. So traditional Medicaid, we have 143,881 individuals. And then in managed care, we have 1,465,477, for a total of 1,609,358 members.
Okay, and how does this number compare to a year ago? Would you know?
I did not come prepared to speak on that, so I would have to go back and look that up.
I can only estimate it for you, Brenda, but it's more than 100,000 fewer people have Medicaid.
That's what I just wanted to know, if it was going.
I mean,
down.
and there are Medicaid has this statistics page. I can send you a link. It's really great. It shows monthly enrollment numbers.
Okay.
And even weekly for some types of reports. And so you can take a look at that and look at fee for service and look at each of the MCOs, and it's really helpful.
Okay, I would appreciate that. Thanks.
Mhm.
But just while I have you guys again here, so for the renewals that have a due date of September 30th, 2023, we had 103,515 individuals. Of those, passive renewal with an RFI sent were 7,220. Individuals sent a renewal packet were 16,967. And then individuals renewed as passive with no RFI were 79,328. And then for October renewal numbers, we haven't finalized those yet, so I can't report on those just yet.
Thank you. So Angela, if you're ready now, we can skip to the network adequacy presentation.
Yes, I am. Again, apologies about that. I'm gonna start. Can you see my screen?
Yes.
Okay, great. So first I'd like to explain what we base this on. The MCOs send us a report every month, I think, or every quarter that basically details their level of adequacy. So the number of providers they have in different categories and how they're paneled for each MCO and whether or not they believe they are meeting their contractual requirements. So when you're looking at this very first map, you can see that the specialty that I'm currently looking at is laboratory, and I'm looking at Q1 of 2023. This one's Passport Molina, and this is the specialist detail that we're looking at. I'm going to switch this to dentists because, not to pick on them by any stretch of the but they are the easiest to see variations with. And so you can see based on the legend on the right that whether or not they have enough adequacy. Red is that they have 50%. And then as they get into this oranger color, they have 80 to 90% to less than 90%. No one, Passport does not currently claim to have more than 90% capacity per county at this time. And then there's several dashboards here, so I'm going to kind of go through them quickly. If you have questions, please feel free to stop me, but I am going to try to get through as much of it as I can. So sorry, I went to the same page. Apologies. I'm going to switch over to this one. And this is the grid detail of what we think in based on claims data and based on enrollment data, the adequacy actually looks like. So I'm going to switch to I'm going to switch to dental. And I will switch to the latest quarter. And we're looking at well care here. And this population is for all members. Now, to explain why these look like little squares here, I'm going to flip back over here and explain to you how we sort of divvied up the population of Kentucky. So my analyst split Kentucky into 2-mile grids and assigned a dot for every 2 miles. The address information and enrollment and eligibility is pretty good, but sometimes if we can't map it exactly, it'll map to the center of a county. So the cleanest way to do that was to assign each member to a specific grid dot. And then it'll populate the grid based on which dot they're the closest to. So this is what the Medicaid population of Kentucky currently looks like. The darker dots, the bigger darker dots mean that there are more people within that 2-mile radius. So it's even a little bit smaller than some of the census tracts. And like you can see, like there are these big open areas, like this is Daniel Boone National Forest, and then up here in the Appalachian regions, there are less people in those areas because they got assigned to a dot like that was somewhere where other people lived. So this is kind of how Kentucky looks. Based on this grid, we then tried to determine, sorry, I went the wrong way, whether or not we felt like we were seeing enough adequacy in those areas based on actual submitted claims. So whether or not providers were submitting claims for the Medicaid beneficiaries that live in those 2-mile areas. So if we're looking currently at dental, when you're looking at well care for Q3 of 2022, there's a little bit of lag with claims data and also with getting the MCO data in for all members where the provider that is assigned to that square has submitted at least 12 claims in that quarter. We can switch that to 1, and you can see it'll change the coloring and there's less red here. So what you have here is the ability to sort of look and see where there are truly potential issues with network adequacy in this area of dental, because although there are people that live here and there are providers that live here, they aren't submitting a lot of claims for those people. Does that make sense?
I think so. Yeah, well, yeah, I mean, one of the things that I was actually going to ask you about was how you figure adequacy when we know that some providers maybe only see a handful of Medicaid members versus a larger panel. So if that's what you're kind of getting to there, that would make sense.
Yeah, that's exactly what we're doing here. So like you can see in this area, in this sort of Davies area, for WellCare, this is just for WellCare. Like if you're looking at just any one of these single dots, so it's Davies County near Owensboro, there are 8,000 children in Medicaid who are within this 2-mile district, and 9,000 adults, which is a total of about 17,000. There are 6 pediatric dentists and 7 family dentists within that range. So you can see that the ratio does not meet, it's a 2,000 to 3,000 per doctor based on the number of claims. And these providers are submitting at least 12 or more claims within the quarter. So if you're looking at this, you can, it looks like WellCare for dentists are well covered in the southeastern area. We're not seeing any issues with A, the number of providers, or B, the number of Medicaid patients that they're seeing. It looks like they have pretty good coverage. They do not have as good a coverage here, even though they may have dentists paneled and maybe meeting the contractual requirements. Those doctors are not seeing WellCare patients in this area. And then again, up here in Northern Kentucky. And if you wanted to look at a different one, say maybe, well, we'll look at Passport. That's Passport Molina now, but yeah. So they're not super great up through the northern area. Again, pretty good in the southeastern area. This Owensboro area is again a problem, a potential problem. And we'll switch over to Humana just to see what they look like. Decent coverage, couple small spots here where they don't have great dental coverage, but or dental, people actually seeing dentists, the dentist actually seeing beneficiaries, but the rest of the state looks pretty good. So based on, again, what the MCOs say they have as paneled providers, but what we're actually seeing in Medicaid through the claims and encounter system, this is a way to sort of pinpoint or maybe look for more opportunities for better adequacy.
Using claims data is interesting. Of course, it still doesn't capture people who don't have claims data because they haven't been able to find a provider. So there is no claim, there's been no service. And I know that there is that secret shopper survey that iPro does, the third-party quality review organization, but is there any other way that you're able to capture demand that the supply isn't meeting?
We haven't currently added in, we know that, adults are now covered twice a year, and kids have always been covered twice a year. We haven't quite added in people who aren't seeing the doctor at all in this dashboard. That's certainly a really interesting way.
Well, particularly with dental, I feel like if I were to show that map to a dentist in Eastern Kentucky, or really a Medicaid member in Eastern Kentucky, they would disagree. They would say that's not the case on the ground. And it may be that these providers are enrolled with MCOs, but either don't have the capacity to see enough patients, or for whatever reason, because of billing, because of prior authorizations and other, barriers to participating, they don't necessarily, provide a lot of services to Medicaid members. And I know that that's the challenge of all this work, but
I think
it would be fantastic to, have a panel of both beneficiaries and maybe a panel of providers kind of work through these maps with you. And, you know, we could kind of think through ways of capturing what you don't have access to in terms of the data.
Yeah, I think that's, yeah, absolutely. That would be great. And to your point, which is a great point. We have set the bar very low. We've basically said the qualifying claims has to be 12. So within this quarter, they only had to submit 12 claims. That could be for 1 patient, 5 patients. So we've set the bar very low as far as like what the adequacy threshold is. We could certainly add to that, right? We could say you have to see a certain number of people, not just submit a certain number of claims.
Right.
So there are definitely ways that we can enhance this and make it more useful. But this is our first shot at attempting it to do it this way based on what the MCOs have reported and what we're actually seeing.
Well, I really appreciate the work that you put into this, and I think it's fantastic to have this kind of dashboard. So definitely appreciate you developing it and also giving us a demo whenever it's, you know, still kind of in the works. But yes, I think it would be really helpful to just, you know, get some input from providers, from beneficiaries as you continue this. And one other thing I wanted to ask, and then I'll see if any of the other TAC members have questions. I know that, you know, the network adequacy standard in Kentucky is 95%, that 95% of the time, a Medicaid beneficiary should be able to access a service that they need within time and distance standards that are in statute and regulation. And is that how you have also, you know, have you built that into this dashboard?
Only on the level of the MCOs. So if we go back, oops, sorry, I went the wrong way. If we go back to the MCO dashboards, but that's based on their reporting. We have not done that based on what's actually being shown in claims data. So this is the MCO reporting to us, their providers, and what they say their adequacy is. So here for laboratory, for Passport in this quarter, they have told us that they don't have adequate coverage in Fulton County, and they are close to adequate in both Christian and Callaway. But according to Passport for this quarter, they meet all of the requirements of the contract.
I think there's a little bit of a disconnect in, you know, or maybe it's just a crude way of MCOs reporting adequacy. It's one thing to have providers in network. It's another thing, and to really meet the network adequacy requirement, as I understand it, to say that every member is receiving the services that they need within time and distance standards. Those are just two different things. So because having a provider in your network doesn't necessarily guarantee that, you know, they're seeing the patient within those time and distance standards. And so I feel like that's where this is, you know, there's still a lot of work to do. And one of the things that I had recommended, or, you know, at least brought up on one of our last calls, was that there be a reporting mechanism so that when a beneficiary is looking for a provider in network and within these time and distance standards, that if they can't find one, you know, of course, it's important to go through the process with the MCO, and maybe the MCO can help you to identify someone. Perhaps they will approve out-of-network care, but that seems to be relatively rare. But that Medicaid DMS would be able to capture those times when that doesn't happen, so that we have a better, you know, handle on how many people are looking for care and not getting it within those time and distance standards. So that's something that if I didn't make as a formal recommendation before, we might want to do that, might want to consider as a TAC. Do any of the TAC members have any questions or comments here? Oh, it looks like it's just about 2 o'clock. One other thing, Angela, do you have an idea of when this will be ready to share, when it will be available for someone to actually, you know, seek out and take a look online?
I believe that our goal is to get one more reporting cycle in with the MCOs to make it available to DMS in production. So Angie Parker and the commissioner and whoever else in DMS would require it. As far as making it public, I don't know that there are any plans for that.
Okay, so who would have access to it once you publish it?
Angie
one of
Parker, the commissioner of DMS, the deputy commissioner of DMS, and whoever else they want to give access to.
I see. So if the MAC wanted to request a presentation, they could get a presentation, or if there was a like open records request. Okay.
Yeah, and I think we could do a presentation for the MAC whenever they ask for it. I can't publish it like on the web.
I see. Okay. All right.
Probably, Emily, what we would do, I mean, of course, we need to fine tune things. And as you mentioned, network adequacy and access and availability time are, it's a drill down type situation. We've been working towards this for a couple of years now, actually. So we're closer than we have been. And, I was a little hesitant in showing this today, but I think we've made a lot of great strides, and I want to assure you that we are working to be able to better define what network adequacy is, as well as ensuring that it is adequate. So it takes a little time to do that, but we appreciate your input.
Yeah, thank you all. We appreciate being able to see it and to give you feedback. So anything else before we move on? All right, thanks, Angela.
Thank you.
Thanks, Angela.
All right. Well, I think if we go back to the usual order of the agenda, we've gone through A, and the next item here is the home and community-based services rate study, and specifically the PDS rate increase. So we had two questions here for you, Pam, if you're still with us. We've asked before, and I think just want to know, if there's an update on the number of participants who have increased their PDS rates, and then how DMS is complying with the directive to make sure that 85% of the increase is going to the going directly to people who are doing direct support.
Okay, so I'll do the first one first about how many have increased their PDS rate. This one I've been struggling with, and I'm still thinking about how I can capture it, because I don't know how many people want to versus how many people are struggling to. So I'm still trying to work through that and see if maybe there's a survey or how we can maybe capture that data. But I will tell you, and just being completely transparent and honest, because you all know that's how I roll. It has kind of taken a lower seat because I want to make sure I'm helping people actually get the increases when they need them. So it's not falling off my radar. I'm trying to think about how to capture that, but I don't know, since I don't know that beginning number of how many people want to increase the rates. And you would think, right, that would be all of them. But I actually spoke to someone earlier this week, and she may be in in the low number, but she had found a way through PDS, as the employer, to have a rate that was actually below even what the increases were for fiscal year 23. So, but it worked for her. It paid her all her employees agreed to that rate. It allowed her to maximize the number of services she was able to get. So it's hard to define kind of what that starting group is to say, okay, 50% have, or 75% have. So I'm still thinking about that. So I haven't completely forgot about that request. So I will continue to think about how to do that. And we are continuing to work with individuals that call us or email us and say, I've tried to do this, my person is not responding to me, or I don't know how to do this. And we're reaching out and helping to navigate those relationships and help that to happen as quickly as possible. The second piece, so I need to clarify that 85% directive was our directive. If they build the 50%, the attestation, they sign the attestation and they're billing one of those services, they can bill the extra 50% instead of what was mandated in the budget increase. And so we're collecting reports on claims, and we're looking at that, and we'll be going back as part of our billing audits, and we'll be looking at that information and gathering that to to look at, to make sure that that 85%, we're looking at the attestations, how the provider said they planned to pass that through. Because there were several options they were given to do. A lot of it was pay increases, but some of them it was through benefits or bonuses. Some of them actually provided, necessary supplies that like uniforms that weren't normally provided, or they were a smaller agency and didn't normally provide scrubs to their individuals, but they found that was of a benefit to be able to do that, to increase the employees. And the story they told was, they had someone that really wanted to start working, but she didn't have the money to buy a set of scrubs. And so before this came through and they were able to do that, she actually went around doing odd jobs for her neighbors to be able to buy her first pair of scrubs so that she could become a direct service provider. So, but
That
we
makes
are
sense.
in the
I guess
process.
the right way to phrase that question then is, how is DMS ensuring compliance with the directive? Does that sound? Instead
So
of
yes, I mean, right.
trying
And
to
so
solve
we will be doing it through the auditing. And as was told as part of the attestation, the providers, when they signed it, that if we find that they did not pass that on, that those that would be could potentially be recouped. So, or they could be put on a corrective action plan. There could be multiple consequences for that. But we are looking at that as we go back and audit now as they're starting to build those services.
That's helpful. And Pam, I have to apologize because I forgot that Veronica also may need to leave early, and I had
Okay, and you promised her, but that's
she
okay.
could
You
go,
can go. That's fine.
we could go out of order for her as well.
That's
So I'm sorry.
oh,
Will you be able
absolutely.
to give us a pace update in a little while?
That's fine, absolutely. And she's my boss.
Okay.
I can't really say no. So yeah.
Can I ask what is the PDS rate?
It is, so I don't have them all memorized, but that's the rate that an individual can pay for participant directed services. It's the so there's a up to a max amount that an individual can decide to pay their employees.
Okay, thank you.
Did that answer your question, Melanie? Or Brenda, I'm sorry.
Yes, okay,
Okay,
thank you.
excellent. Okay. Veronica, sorry about that.
Oh, no, that's okay. I'm not sure what it is you want me to address.
Oh, okay. Well, I figured any of the items on the agenda that you were going to speak to, I thought we could just cover now before you have to hop off. And if there aren't any specific items, then we can certainly hop back to PACE.
Yeah, I think Team Medicaid has it pretty well covered.
Okay.
And
right.
if there is something that pops up after I drop off, I'll be sure to follow back up on. But thank you. I appreciate you.
Okay. All right. Well then, Pam, I guess we're back to you.
Okay, let me
Sorry for jumping around, everybody. But yes, with the PACE program rollout, you've just been giving us updates on how that's been going.
Yes, so I have kind of some exciting stats to share. So these are as of 10/1. We now have 129 active participants enrolled in PACE. We have 3 providers that are serving 17 counties. We have 7 new providers that will be serving an additional 41 counties that are in the process of CMS approval. 6 of those are on track to begin providing services in 2024. The 6th one is in 2025. That onboarding process is very extensive. The on-site reviews that are required, and some of these providers are also building from scratch. So they're buying land and they're actually building their PACE centers, or they are doing extensive renovations of existing buildings that they have purchased to meet the requirements to be a PACE provider. But very excited with how PACE is going. The feedback that we've received from participants has been overwhelmingly positive. We have had a few that have said, you know what, this isn't for me. I would rather do waiver, and have come and left. But for the most part, we've heard nothing but just satisfaction, and have seen a lot of success stories from the PACE providers. And from the members that are getting those services. I have some links that I will I'll put in the chat that you all can go out to and see kind of where are the counties that the individuals are the agencies are serving, and some of the other just general info about PACE, because I think I saw the what services are covered portion of that. So the interesting thing about PACE is that it is designed to cover any service that the individual needs that is determined medically necessary by their interdisciplinary team. So it includes preventative care, it can be acute care, it can be long-term care, it can be services that meet their social needs. So it can be, you know, around nutrition, it can be recreational therapy. It's really anything that individual needs that interdisciplinary team, when they meet, that they believe is medically necessary for that individual. So it's a great addition, I believe, to our long-term services and supports, and I'm really excited to see how it continues to grow.
Yeah, that's fantastic. Anyone have questions about PACE? All right, and in terms of kind of enrollment or just really promoting the program, are you doing that in a pretty targeted way, Pam?
We've done, so there's been, you know, we have put a lot out on the website. We have talked, we've developed kind of the relationship with our Money Follows the Person team, as well as just encouraging the collaboration between the case managers and the PACE organizations and connecting them. So really that they can be referral sources for each other, because, you know, right, one service may work better for somebody than a different one. So we've been really targeting the communication between the agencies and helping them, you know, making nursing facilities aware, making providers aware. We have some, you know, as we go and speak about PACE, we have just some general, like, really quick pamphlet type things, just easy to read, that we send out. But hopefully in 2024, as we expand out to more counties, we're going to expand that sharing of information as well, since we'll be starting to serve so many more people. But I like to talk about it anytime anybody asks me about it. If you can't tell, I'm kind of excited about PACE.
Well, it's nice when you have a bright spot and whenever
It is,
other things
exactly.
are more
It's
challenging.
nice
So.
when there's the sunshine, yes. So.
Mhm. All right. Are there any other items on this agenda that would be yours to kind of report on?
I can
I
talk
guess the
about
1915I and
the
1115.
1915I. Yeah, I can talk about the 1915I. So the 1915I state plan amendment for serious mental illness, as well as addressing homelessness. So it's providing supported housing and employment to individuals with SMI and SUD. We had our town hall on September 25th. The recording and the slide deck have been posted to that. So I'll put that link in the chat. We will be doing in-person sessions. I believe there are 5 areas scheduled throughout the state. We're working on getting the locations right now, but those are going to happen in early to mid-December. So we'll get that posted as soon as we're working on getting all of the locations nailed down right now. But there'll be placeholders that'll go out to tell people, you know, these are where we're targeting to have them. Look for more information soon. Those will likely go out within the next couple of weeks. If anybody knows, just a plug, anybody knows of an area that likes to have town halls, or that would offer up space for town halls, or where, you know, would be a central location and be easy for individuals to have access to, if you reach out to me or Kelly Clays, I would appreciate that. So shameless plug for help finding locations if anybody has any, you know, good ideas for places to have them. We try to, you know, target places that are easiest for people to get to. We've done a lot of libraries, we've done some schools have let us use gyms, so that type of thing. But more information coming very soon on those, and we're targeting to have that waiver application submitted to CMS by end of December, beginning of January.
And that's the 1915I, right?
That is the
The-
1915I. Yeah, I will
Yeah.
have to, I don't know if Leslie is on or one of her, of one of the other behavioral health staff to speak to the 1115C, but that is the 1915I, which will be in my, will fall in my group.
Pam, this is Leslie. The 1115 is currently with CMS for SMI and includes the recuperative care and the expansion of IMD for SMI for parity related, just like we do for SUD. And that's at CMS now.
Thank you, Leslie.
Leslie, can you remind me, I know that there was public comment, that period ended, and the next step is that you basically wait for CMS, right?
That's
Uh,
correct. And I don't have a time frame right now that
Have-
they will be approving that.
Have you summarized those comments? Is that something that's been published and I maybe missed it?
Yes, they're on the website. Let me,
Okay, I might have
I'll
missed.
send you a link later. Is that okay?
Yep, that'd be great. Thank you.
Okay,
If
all
you
right.
could just send it to Kelly or Aaron and get it out to the group, that'd be great. And Pam will be sure to share the town hall, whatever sort of save the date that you all put out.
And also just real quick, Emily, want to remind everybody that the 1915C waivers are posted for public comment right now. It is actually the same link as the, where you can go to get to the recordings. It's right above. It's right above that in the link that I just posted for SMI, but there is, each application is posted with a summary of updates, beside it. And that, we've got about, well, a little less than, 2 weeks left. We've got to 10/27 and we'll be closing public comment on
Okay.
those.
All right, thank you.
Thank you.
So one other thing, I know that Arthur has asked to have that item on the agenda, that the proposal to overhaul the Michelle P and other waivers. And I think, Arthur, just correct me if I'm wrong, I think that we're going to put that off until perhaps December or another month when a guest speaker can join us. I do think that's the case, Pam, but
Okay,
if
that's
we're
fine.
going to hang on.
Keeping me on the edge of my seat. I'm excited to hear Arthur. So
Yeah, we're building up the anticipation.
exactly, yes.
No, it's a health related issue that's delayed this individual from being able to join us. So
Arthur's on.
He is. Sorry. He's sorry. But. He's sorry, but. The person. He is sorry, but the person who wants to talk, they can't. They can get out of. He ain't can't. He can't get out of his home right now. The person want to talk, he can't get out of his home right now.
Arthur, that's completely understandable. We'll just wait until he's ready.
Absolutely.
On
And
the
Arthur,
agenda.
if there's anything that we can do to help him be able to participate, let us know if there's anything that we can help.
He said thank you for your patience.
All right. I know we've kind of jumped all over the place, but I think the next item, if we go back to.
By the way, if he has his video, by the way, if he has his video on, Oh, it will break up. That's why it
Okay.
don't.
That, Arthur, that's all right. When we vote at the end, if you can maybe try to turn your video on, we'll do that, but I think we may have a quorum even without it, so.
He said, okay, he knows that.
Okay.
He said, thank you.
All right, sounds good. Now, Angie Parker, are you going to be telling us or giving us kind of an update on the DMS report on the hospital rate improvement program?
Yes, I am. I don't have anything to report yet, though.
Not ready.
It's still being audited. So hopefully by the next meeting, I'll have something for you.
We'll keep it on there. All right, thank you. The next item here is certified CHW reimbursement implementation, just an update on that and where things are at with the regulation.
Yes, hi, this is Justin Derringer, Acting Director for Division of Healthcare Policy. So the administrative regulations moving right along in the promulgation process. We have some comments that we're going to insert after working with a couple of groups, including yourself. And so we're going to make some changes to that regulation. Implementation is going well. We're seeing an increase in providers billing every month. I think we're still waiting for the system to kind of catch up on the fee for service side, but the MCO numbers are, increasing. I think they increased 40% from last month. So we're having a lot of providers bill for CHW services, and we are trying to finalize the last piece of the dental CHW billing issue that we've been having. So we've sent, I think we've sent 6 different options to the contractors with the MCOs to make sure that those options would work in their systems. And they've sent us back a couple of options. And so we're kind of narrowing it down to one with them, and we'll have that done soon. But it's going really well so far, and we're excited to get that, payable on every system and dentist billing. And I think it's just going to continue to increase from there. So
yeah, that's fantastic. Well, good. Thank you for that update. One thing I've heard recently still from some CHWs is that they are a little unclear on, what documentation is necessary. I know there isn't like real specific guidance. They've kind of been generally told that there has to be something documented in the chart, but I think people just want to know that they're doing it correctly, honestly. So.
Yeah, I think we clarified a little bit of that language in the regulation. So.
Oh, okay, great.
Hopefully that will help you.
Okay. Does anybody have any questions about that? And if I didn't kind of spell it out, it's community health worker for anyone who's not familiar. I say CHW too often. All right. Thanks, Justin. So now we're back down to our new business items. And I think really the MAC and TAC orientation packet shouldn't necessarily be new business still. That's something that we've discussed in the past. Just wanted a status update on where that's at. Oh, and I skipped the get contacted option. So why don't we touch on that first? This is something we also discussed on the last call. There's a new option for people to kind of select get contacted, either when they're online on Connect, or even now, I think they can, somebody on the call center can facilitate that process. There's even a new, form that people will get in the mail if they're no longer eligible for Medicaid. They can select get contacted, and an agent can reach out to them to help them with, shopping for a qualified health plan and enrolling. Originally, when this was being discussed, before it was ever live, we'd been told that connectors were going to be added in 2024. And I've heard some different things. Some people weren't aware that connectors were being added and didn't think that that was happening any longer. So I just wanted to really verify if that's still the plan and if there's kind of a general date in mind for when that will happen.
Yeah, hello, it's David Derry from DMS, the Exchange. Yeah, we're definitely looking at having that option be available for connectors as part of either an SOW next year with Deloitte or a change request. And we're looking at doing something that no one else in the nation is doing, and having a battery of 2, 3, or 4 questions really short to try to help that individual who says they want help to get either to a connector or to an agent, whichever is going to be best to help that individual. So
So
it's
directing them a little bit more.
yeah, like if someone says, I know I want health insurance and I don't want financial assistance, that's a no-brainer. You need an agent. And if someone says, I want to explore options for food stamps or SNAP or any other programs, that's obvious. That's a connector. And then maybe just 1 or 2 really quick questions on income, family size. Not anything that looks even as complicated as the pre-screen, but just to get them pointed in the right direction. We've
I
seen
think
about
that would make a big
sorry.
difference. I think
Yeah.
that would make a big difference in accuracy in like getting people to the right place the first time rather than accidentally referring somebody to an agent who needs a connector or just needs even help with a totally different program. I do still have a slight concern. I think there should at least be the acknowledgement that not all agents sell all products.
All
And so
agents sell all of the plans that are on our exchange.
is that the case?
Yes. All
Okay,
agents sell all plans that are on the exchange.
okay.
They might
Well,
not
and
be,
that-
they might not be appointed to, they only need to be appointed to one to sell for all, but they can sell for all. They get
they
commission
have
for
the
all,
ability to,
and
okay,
yes, yep.
okay. I think there's just been some concern
Sorry
that
for
they
that
direct
confusion, yeah.
people into a particular product.
Oh, that'd be
Um,
horrible if you like.
Connectors are a little
got-
more neutral.
Yeah, if you got sent to, connectors are neutral, which is a huge advantage. It also is a slight disadvantage where an insurance agent is the only person who can look at someone's circumstances and then recommend what they think the best plan might be.
Right.
There are advantages and disadvantages to both scenarios, obviously.
Which is why I think having both,
Oh,
you know,
yeah,
available
yeah,
to get
it's-
contacted is a great idea.
It's a great idea, like we usually do with the exchange. We mirror what the FFM is doing. And then, which is what it's doing now, it behaves
Yeah.
exactly the same way. But then because we're a state-based exchange, we always need to be thinking about what we can do to innovate and do
Mhm.
it better.
With the advocates that we know in other states and even some of our national partners, we've not heard great things about that, unfortunately. So we want to make sure that we're doing it better than the way the FFM is doing
Yeah,
it.
of course. I actually,
Yeah.
that's what you're here for, Emily, to yell at us in a great way. We've had about 6,000 referrals since it began. And right now it's hard to line up if a referral led to an enrollment because it starts out with so little information. We're adding an innovation next year to where they can at least self-report that it led to an actual enrollment so we can get some better data. But it seems to be working along everything else and all the hard work the whole community is doing because we're continuing to gain enrollments in a period of time that if it weren't for the unwind, we'd be actually seeing enrollments go down. We started the unwind at about 58,000 active enrollees, and then that plummeted by almost 1,000, actually over 1,000 because people went to Medicaid. I think we're the only state in the union that does that gets people over to Medicaid early if they are qualifying, even if they were on a QHP. But then we've been gaining ever since, and we're approaching 62,000. So all these tools seem to be working of getting people enrolled. But we are definitely open to anything that can be done to improve things, Emily, and everyone else.
Yeah. So just one other question. I know that you've been trying to kind of rein this in just for qualified health plans because originally it was, people who were looking for Medicaid enrollment were getting sent to agents and agents were referring them, so there was some changes made so that it was more clearly like specifically targeting QHP eligible. That's how at least what I remember hearing. But now the agents are being paid for Medicaid applications. Are Medicaid eligible folks also being put through the get contacted?
They can choose that, of course, but as far as being transferred from the contact center, which is the primary flow, no, of course not, because that wouldn't make any sense because once you become eligible, you're automatically enrolled. The agent really has very little to do with finding an MCO for someone.
Oh, no, it's not about that. I mean, it would be the application and
Yeah.
agents being paid for the application.
Right.
You-
So I
You
mean,
have
if
to
some,
apply to be found eligible.
yeah. Right now, the primary flow to Connect on Demand is someone's done the application at the contact center and they're ready to enroll. And then instead of having that rather complicated back and forth over the phone with someone who's not an insurance agent about deductibles, copays, and everything else online, they just send them on over to
Okay.
the,
So there's not a plan to start like directing Medicaid, potentially Medicaid eligible folks who want to apply over to agents. That's not
no,
part
oh,
of
no
the-
heavens no.
Okay.
No.
Well, I wasn't sure because now agents are being paid to do Medicaid applications, so I wasn't sure if that was part of the plan. So thank you for clarifying it.
Again, double-edged sword. The great thing about connectors is they have to help anyone who comes to them, which is wonderful. If I was smart, or I would be a connector, definitely, for sure. Insurance agents are running a small business, and as long as they don't discriminate, they unfortunately do not have that same legal requirement. So by offering them this small one-time fee, it at least compensates them to the point of, hey, I'll help you out, and if it goes the wrong way and I don't get paid, don't get a commission, then at least I got something out of it to try to broaden the net that we're cast to try to help people. Just for clarification there too, they don't double dip. If an application leads to a QHP, they're not going to get paid a commission and get paid the $50. It's
They
only
probably
for
get the
a
commission instead of the 50, yeah.
yeah, and it's a lot higher than that fee, but we wouldn't. I know I wouldn't feel comfortable with paying someone and then having Anthem pay them on top of that. So
Okay, no, it's really helpful to know that this Get Contacted is going to really be targeted to QHP enrollment.
yeah, the only thing that where it's not targeted is that anybody who clicks on that from the public can then choose to use whatever options are available.
Sure. Okay, thank you. Miranda, do you have any questions about that or any of the TAC members?
I really appreciate all the updates, David. You said that there was a change going in for, well, I guess the only thing I wasn't clear about, you mentioned the like 2 to 4 questions to help direct people and also adding the option for connectors. Would those go into effect at the same time?
Yeah.
And
Oh
do
yeah.
you have a
we
timeline?
Timeline, to be honest, probably third quarter next year. So I mean, I'm just being honest.
You say
Mm.
fourth quarter,
Third quarter.
third quarter of next year. Okay.
And that's just a really rough sketch given everything else is going on.
Yeah.
Thank you.
Yeah. I absolutely hear you, but I can only answer what I can answer.
No, we
I think it will be a great idea. I mean, nowhere else can you go to one place and it'll get us closer to that magical no wrong door, no wrong platform.
That's what we're looking for.
And it should cut down on traffic at DCBS too. So thank you all.
All right. Well, we'll look forward to more updates on that as it gets closer. And, if you can tell us in the future how Get Contacted is working, if you do kind of start to get a sense of how many people are enrolling and, if there's any sort of data you can report from that, that would be great.
Yeah. If we can get the holy grail of knowing through this virtually anonymous tool, how many of them lead to an enrollment, which we're working on, making it, trying to trick them into telling us the information we want. That'll be a helpful tool as well.
Well, now I think, can move on to the Mac and TAC orientation packet. And Kelly, is that something that you've been working on?
I am, yeah, that is something that I've actually put together and have submitted it to upper management for review, and they are still reviewing.
Okay. Is there any kind of input that we can provide at this point?
No, Emily, this is Veronica Judy Cecil with Kentucky Medicaid, and we're just reviewing it, but then happy to send it out, and certainly it could be an iterative process, if you all take a look at it and see if there's anything we need to change, we'll certainly welcome that. But it's still undergoing internal review. We'll try to kick that out as soon as we can.
That sounds good. Thank you.
Yeah. They've done it, by the way,
I'm assuming
a
this would
fabulous,
be,
they've done a fabulous job of pulling it together. So we're excited to launch it.
yeah, I'm looking forward to seeing it. I do think it will be really helpful for new members and even for current members, honestly. So
Yeah.
we can all
Agreed.
brush up on some things.
I agree.
Yeah. Brenda.
No, I just said yes, that will be helpful.
Oh, okay. Gotcha. I try to keep an eye on the boxes whenever I can see them. All right. Anything else related to that or anything we've covered so far? I just want to make sure I'm not going too fast. We have a couple of other new kind of discussion items. The first is language access, and this is an area or an issue that Miranda has, and I have discussed quite a bit, and she wanted to put this on the agenda to have a larger discussion with DMS and the MCOs.
Yes, thank you, Emily. So I wanted to put this on the agenda today because I heard from a couple different community partners about issues they were having with getting interpreters for Medicaid patients for their appointments. And one of them, I believe, is on the call. Jennifer, do you want to share? Hi, thanks.
Yeah, hi, my name is Jennifer, and I'm the Refugee Health Promotion Coordinator with the Kentucky Office for Refugees. And so we provide funding for programming directed at supporting the health and mental health of refugees around the state. And some of the funding that we provide goes to support community health workers. I heard you all talking about community health workers before, and we have regular meetings with our community health workers, and they often report back that they experience challenges in helping their clients connect with providers that are accepting Medicaid, but are resistant to providing language access. And oftentimes there seems to be a misunderstanding of the roles and responsibilities around providing language access. Sometimes they've reported to me that a provider may explain through the community health worker that their understanding is that that is the responsibility of the MCO, and then they're explaining to the community health worker to explain to the patient that they need to contact the MCO and schedule an interpreter for that service. And so it just seems like there's a lot of confusion around like what's the responsibility of the patient to make sure that there is an interpreter available, what's the responsibility of the MCO, what's the responsibility of the provider, and then how that can be communicated clearly to folks, especially folks who, our medical system is very new to them, and then how community health workers can help explain that when it doesn't seem to be quite fleshed out, maybe. So we thought if we could maybe help get some clarity around that, and then communicate that to our partners, and that would be great.
Yeah, I appreciate you being here today, Jennifer. Yeah. Miranda, did you have anything else you wanted to add before we just open it up to DMS and MCOs? I think we're basically looking for some guidance here and just clarification. And it sounds like there's been a lot of inconsistency at best.
Yeah, I was concerned to hear Jennifer's story and heard from an interpreter provider who also had a similar experience that they had to work through an MCO rather than through the healthcare provider. And so I was concerned about that because I wasn't sure that was the correct process. And yeah, so I'm not sure if there's someone on today who can address this.
This is Stuart on with WellCare, not somebody from DMS, but the requirement is providers. If you get federal Medicaid funds, you are required to provide interpreter services. That's an Office of Civil Rights law. But we at WellCare, you are required, if you can't for whatever reason, notify us. We have a customer services that, either the member or provider or somebody on behalf of the member can arrange for it. We will arrange it. We have locally contracted vendors for interpreter services. We will arrange it, but you got to tell us. So, I mean, the provider is required, but if they can't, they have to tell the MCO, and so that the MCO can arrange it.
I think it's great on the one hand that WellCare would do something that WellCare isn't really required to do, because like you were saying, it is the provider's responsibility. And that's how I've always understood it. I ran a language access program at Family Health Centers years ago. But I wonder if that's maybe adding to some of the confusion where providers who are technically responsible are now kind of putting it off on the MCO, saying like, don't go through me, the MCO will pay for it. And maybe that's creating some of the delay and the confusion, because otherwise the provider would really be the one expected to provide it. Is that?
Yeah, I mean, that probably is the case. There are probably providers who don't know that. They honestly don't know it. They think it's the MCO's responsibility.
Yeah. And I don't know when DMS, makes this expectation clear to providers, or if there's an opportunity to maybe, remind providers of their responsibility. But that may be part of the solution here, to make sure that providers understand that this is something that's required of them.
And I don't know, I mean, we have, and I'm sure all the MCOs do, and we have a diversity and equity council. And this is one of the things actually that we're targeting this year. We're looking at this and gaps. We're looking at the most prevalent languages and gaps, lack of individuals getting interpreter services and why they're not getting. And so we're definitely looking at that, and we'll be doing provider education and outreach regarding that, which will help. And then I just forgot there was something else related to this, but anyway, I mean, we can definitely, MCOs can educate providers about this as well.
Yeah, this is Veronica with Medicaid, and it's always good to know and understand when there are challenges. And I think, we always discover there's an opportunity to re-educate and to make sure everyone understands what requirements are. So I appreciate you bringing this to our attention, and we'll certainly take this back and see about what we can do to clarify requirements and make this easier on the member, because it really is about the member understanding what they need to do next and making it very clear and accessible. So we'll take this back and see what we can do to improve upon it.
And I just want to add, I think, like I said, I think it's great that an MCO like WellCare would want to offer this, even though it's truly required of the provider. I wonder if perhaps the provider should be the one making the request, if they do, if they need that financial assistance, if it really is, a financial burden to provide, or if they just don't have, access to an interpreter, because sometimes when you don't have a large population of, patients who speak other languages, you may not have those contracts set up in advance. And so I could see some circumstances where it could be really helpful to have WellCare's assistance, but maybe it not be put on the consumer to make that request, but maybe the provider, so that it's always going through the provider.
Yeah, I agree with that, Emily. And I do think, and I'm not going to speak for the MCOs, but I do believe they all offer some type of service like that. And primarily because they are responsible for if somebody calls into customer service or needs help navigating their benefits, they're required to have those interpreter services available. So again,
just like TMS with the call center.
That's correct. That's correct. So certainly we'll take it back and see what we can do.
I just remembered what I forgot. So if this happens, we would also encourage the member to file a grievance And that way we will know. I mean, we will capture it on the grievance. What's the problem? They didn't provide interpreter services. So that would help as well.
Yes, absolutely. To know the scope of the issue and be able to do some intervention. Jennifer, if
He said he will have more to say about this issue. At next meeting.
okay, all right, then Arthur, I can leave language access on the agenda.
Yeah.
Okay, sure.
Sure.
Jennifer, did you have any other questions or anything you want to add? I know I just kind of suggested a change in process, but I want to make sure that that sounds like something that would be more beneficial for the clients that you're working with.
Absolutely. And I think also what you all were mentioning about like how to file a grievance, because I think some of it is a misunderstanding about process, but then we have had some providers who they are made aware and then they still will not comply. So I think at that point to understand what the grievance process is. So would you say first step is through the MCO and then to Medicaid itself, or is it always first through the MCO?
Right. For a managed care member, the grievance would go through the MCO. But I do want to just clarify, we do not enforce the Office of Civil Rights requirements. So ultimately, a complaint can go up to the Office of Civil Rights if a provider is in violation of the federal rule.
Okay. The first step though is to work with the MCO.
Yeah, I mean, certainly, and it always is helpful for us to have examples because it's that evidence that we have to use to take to go ensure compliance with whatever the requirements are. So I kind of echo Stuart in the fact that I know it's a burden to do, but anytime that something can be escalated in the form of a grievance helps us have the information necessary to take action. But if it is a managed care organization, then it goes through that managed care organization, and then fee for service goes through the customer service typical process. But I think, one of the things, again, we can take away is probably providing a very simple visual on the process about language access and just kind of put all the information in one flyer type format and what to do if somebody's if somebody's not in compliance and what those steps are.
That would be a fantastic project, very helpful for all our partners.
Would you say almost a decision tree, Veronica?
Right. Mm-hmm.
Okay. All right. I'm just making some notes.
That sounds great, Veronica. I would be really excited to see that. So if someone does have managed care, it sounds like the first step is to go through their MCO. If it should ultimately be Office of Civil Rights complaint, would the MCO escalate that, or is it up to the individual to do so?
Yeah, it's the individual who's been who's had the challenge.
But let the MCO know, the provider.
It's first step.
Yeah,
Yep.
I mean, we'll address it with the provider.
Yeah. Because I do believe most of the MCOs in their contract with providers require they make that very clear. The provider is responsible.
That's good to know. Thank you. Anything else on that topic right now? Well, we will keep it on the agenda, so we can address this again next month. Or not next month, at our next meeting.
Thanks for coming and speaking to the issue, Jennifer.
Thank you all.
Right, our next item is open enrollment messaging and the value added benefits side by side, which is always something that we like to promote as part of open enrollment. I know open enrollment is very different this year because of Medicaid renewals. So Veronica, are you going to tell us a little bit about this, or someone else on your team?
No, I might phone David. David's prepared to give. I know he's been working on open enrollment.
Hey again, I assume now you're talking about MCO open enrollment, right?
Yes, Medicaid, MCO open enrollment.
And my cousins at QHB, we love them too.
Not Medicare, not QHB.
Yeah, right. All of our agents would duck and cover because it's Medicare season. But MCO open enrollment, yeah, that side by side is coming. We're hopefully going to get it to y'all posted on our website, both the KHB site and the Medicaid site, January 1, hopefully even before. Because we know how valuable that is. It's such a valuable document that the MCOs really like to go through it with a fine-tooth comb. But that should be by January 1st, hopefully sometime in December, and someone else on the call can correct me if I'm wrong. Hopefully wrong in the right direction.
We're going to obviously try to align it with the communication that's going to go out to members to notify them of the ability to change MCOs during 2024 and refer them over to the website so they can make an educated decision about whether or not they want to change.
Now,
And
I think
there will be a
after a different plan. Is there going to be a notice, like an actual mailed notice that is sent? Okay, I thought before that I'd heard that there wouldn't be, so that's good to know.
And then December 16th will be when persons can use SSP to request a change of MCO without reason, without cause. And that can be any SSP user. So connectors, people at home, agents, contact centers, whoever. So we've taken away the regular open enrollment. We've added something better.
Veronica, are you thinking that notice is going to go out by December 16th or before?
Oh, yes. Yeah.
December 2nd, I think.
Yes. Yeah.
Yeah.
One other thing to note is, so in terms of the notice, anyone who's currently enrolled will receive that. And then as new enrollees come on, they'll receive, after their notice of eligibility, they'll receive a letter letting them know they can change their MCO at any time in the letter that notifies them about their MCO. So we're kind of doing a catch up for everybody who's currently enrolled, and then going forward during 2024, new enrollees will get a notice as well.
I just wanted to add on the side by side, someone on my team is working with the MCOs on getting that all together. We had hoped to have it complete by this week, but we're also going to have to, get it interpreted into Spanish too. So it should be hopefully in the next few weeks.
Okay, that sounds good. And will there be like a kind of a messaging toolkit, social media that connectors and others will have, or are you just expecting? Okay. Is that a yes?
We'll release it out. Yeah,
Okay.
we'll release it out.
Sounds good. All right. Well, thank you. And I also saw in the chat, Anthem, Humana, and UHC all mentioned their interpretive services. So thank you all for that. We appreciate it. Any extra education with providers and reminders would be great. David, did you have anything else related to open enrollment?
No, just that we're improving open enrollment toolkit and sending that out almost every other week. There's something new we've added to help connectors or agents or both. And they're really looking forward to Fridays at 1:30 when we send out a blast of what the latest and greatest is. So when it comes time for that MCO change thing, it'll be all over the world. They'll know.
Sounds good. Miranda or any other TAC members, do you have questions about open enrollment? Okay. Yeah, I'm looking forward to seeing how this new type of open enrollment a longer period of time goes. And definitely planning on sharing out information about it whenever it's available. So I think even though we've jumped around a lot on the agenda, I'm almost certain that we've covered all of our items. So anybody who, if you notice that I skipped over something, please let me know now. Or if there's anything else that you want to bring up, this would be a good time to do it. All right. Then I think we can move on to recommendations, which is our next item here. I had kind of jotted down from our discussion about language access, a possible recommendation that DMS send out a letter to providers to clarify their responsibility to offer interpretive services and create a visual decision tree to explain how a beneficiary can access language services and what steps to take when an interpreter is not provided. Does that sound like right? Did I get the wording right there? Do we want to make any changes to that?
So the second part was create a visual decision tree for members.
To explain how a beneficiary can access language services and what steps to take when an interpreter is not provided. And if you want to work on this, Miranda, and bring something back to the next meeting, we can do that too. Whatever you all feel comfortable with.
I think this is good for now. The only other thing on my mind is just how members will get that visual decision tree, like how it will be sent to members. But I think probably to focus on creation of the materials first.
Yeah, we can make another recommendation later.
May we table? May we table this one until
Next meeting.
Yeah.
You want to table the recommendation until next meeting?
Yeah.
Okay, all right. Well, Veronica, if that is something that DMS is still willing to do, I would say, at least with the visual move forward, but, and we're happy to provide input there, but we will make a formal recommendation later.
Yeah, we don't need a
Since you already
recommendation.
kind of offered, I figured.
That's correct.
Thank you.
He wants to write out his thought
Okay.
on this.
All right.
Because it will take too long if he try to even
Okay.
if he tried to explain his his issue. His issue right now. He said thank you.
Absolutely. So we'll have that on the agenda, Arthur, and you can come prepared with your thoughts and any potential recommendations, and the same to you, Miranda, if you want to take some time to kind of work that out. Then the other recommendation that I had in mind around network adequacy, I think there's been good progress on that dashboard, and a good conversation there about that access piece and how we really get to not just seeing that there are providers in network but that beneficiaries are able to access services in the time and distance standard. So the recommendation that I would put forward is that the consumer TAC or that DMS create a process for beneficiaries to report when they are unable to access an in-network provider within time and distance standards. That way, I feel like, you know, we would have a much better sense, a comparison of here's the network of providers that are enrolled with the MCO. Here's the access to services. And, you know, we'd be able to see where there are gaps in there. And also, there may be some opportunity for DMS to intervene in certain cases when someone needs out of network care. So that would be my recommendation. I'll repeat it since I kind of explained it as well. So this is what I would say that, you know, would be our official recommendation. That DMS create a process for beneficiaries to report when they are unable to access an in-network provider within time and distance standards. Can I get a motion?
I motion to recommend.
A second?
I second.
Was that you, Brenda?
Yes.
Okay, and I heard you too, Arthur, but I think Brenda might have beat you. It was a tie. All in favor, say aye.
Aye.
Any opposed? All right, motion carries.
And
Thank
then,
you.
Kelly, would you mind to just send me that in writing, please?
Yeah, absolutely. I did write it down, so I will get it to you. And then, are there any other recommendations? Okay, well, you know, for the next meeting, you know, language access is one area where, you know, I would like to hear some recommendations. Of course, always come prepared with ideas for other recommendations. That's one of the benefits of participating in this TAC. And the next meeting, well, number 8, MAC meeting representation. I'll be at the MAC meeting to represent and to report on our work. And as far as the next meeting goes, we do need to reschedule. I was originally planning our Kentucky Voices for Health, our annual meeting is going to be on December 5th. It was originally going to be on like the 4th and we had to move it. So probably the easiest thing to do is just work with you, Kelly, or with Aaron on finding another date. Maybe a few options that DMS is available, and then I can pull TAC members.
Yeah, we can do that.
Okay, but apologize for that. And then the MAC meeting schedule, so that's where the entire advisory council comes together. Those are always the 4th Thursday at 10 a.m., although that may be with the exception of Thanksgiving. So, but that schedule is usually up on the MAC website. If anybody's interested in attending, I do represent our TAC there, but everyone is welcome. It's a public meeting and it is now fully virtual. So that's a nice thing, and recorded if you want to catch up on it later. So we've really appreciated that. That was actually one of our consumer tax recommendations, that those meetings be recorded so that people could access them later. And that's been really helpful. All right, well, I think we've covered everything. So I'll ask for a motion to adjourn.
I motion to adjourn.
All right, thanks, Maria.
Yeah.
Second, Arthur. Okay.
I think he seconded.
Yeah, he beat you that time. All in favor, say aye.
Aye.
Any opposed? All right, sounds good. We are adjourned. Thanks, everybody. It was good to see you, and have a good day. Bye.
Thanks,
Thank
everyone.
you. Bye-bye.
You too.